Transfusion in myocardial infarction remains a controversy. Currently, the only recommendation is from European Society, which tells us to transfuse in NSTMI only if the hemoglobin is less than 7. European Society and AHA both remain silent in STMI as well as NSTMI when to transfuse. The American Blood Bank tells that it cannot give any recommendation based on the low power of evidence available right now. So, we will look into this trial, which is the reality trial published in JAMA, which looked at the effect of restrictive versus liberal blood transfusion in major cardiovascular events and among patients with MI and anemia. Will this trial change the practice or will it provide any evidence? Let's see. So, as we all know, that even moderate levels of anemia is associated with increased cardiovascular mortality compared to normal hemoglobin values in the context of acute coronary syndrome. Transfusion is often considered to be indicated when hemoglobin level falls below 10 with large variations in clinical practice due to the lack of any robust data. Observational studies have yielded conflicting results. RCTs have been only two with very small sample size population of 45 and 110 each in this particular setting. The study question in this trial to determine whether a restrictive transfusion strategy was clinically non-inferior to a liberal transfusion strategy. The methods, the study design was randomized open label international clinical trial. The study duration was 57 months from the first patient enrollment. The duration of recruitment was 40 months and duration of participation for each patient was 1 year. The study site was France and Spain. The trial population, aged at least 18 years and having an acute myocardial infarction with or without ST elevation with a combination of ischemic symptoms occurring in 48 hours before admission with elevation of biomarkers and a hemoglobin level between 7 to 10. Enrollment could be considered at any time during the index admission for the myocardial infarction. The exclusion criteria: shock at the time of randomization, that is a systolic blood pressure less than 90 with clinical signs of low output requiring inotropic drugs. Myocardial infarction occurring after percutaneous intervention or coronary artery bypass graft. Life-threatening or massive ongoing bleeding, this is to be judged by the investigator. Blood transfusion received in the past 30 days. And lastly, malignant hematological diseases. Randomization and intervention. It was a 1:1 randomization. A web-based randomization treatment was used with a centralized block randomization list with blocks of varying size ranged from 2 to 6 stratified by center. Two strategies for RBC transfusion in patients with myocardial infarction and anemia will be assessed. A restrictive transfusion strategy where transfusions were withheld unless the hemoglobin is less than 8 with a target of 8 to 10. This was initially 7, which was later modified to 8. A liberal transfusion strategy where the PRBC was to be transfused if the hemoglobin was less than 10 with a target of 11. Both strategies were to be maintained until patient discharge or 30 days after randomization. This is the flow chart. After informed consent, there was to be randomization. Then they were to be divided to two groups, the liberal and the restrictive. They had to undergo a clinical follow-up until discharge. Then they had to be followed up by visit or phone call at day 30, 6 months and 12 months. The primary outcome. The primary clinical efficacy outcome was a composite of major adverse cardiovascular events at 30 days, which was defined as all-cause death, non-fatal stroke, non-fatal recurrent myocardial infarction, or emergency revascularization prompted by ischemia. The secondary outcomes. The individual components of this composite outcome at 30 days and 1 year, cost effectiveness analysis, and adverse events. So, total 668 patients were eligible for randomization, and they were finally randomized 666. Out of these, two were excluded, one did not give consent, the other withdrew consent. So, out of the 666 that were randomized, 342 were to the restrictive transfusion group and 324 to the liberal. In the 328 patients who were in the restrictive group, they received transfusions. 13 patients underwent transfusion even when their hemoglobin was more than 8. So, they were included in the intention to treat analysis. Finally, in the group that was receiving liberal transfusion, 323 received transfusions. One did not undergo any transfusion. So, coming to the demographics, the age was median around 70s. Sex was predominantly male with nearly 56 to 58%. Race predominantly white. BMI was around 26. Hypertension was the most common risk factor associated. In terms of the myocardial infarction type, most of the patients were NSTMI. 31% were around ST elevation LI. Killip classification at admission was again Killip class 1 was most common, around 57%, followed by 2. Class 4 was around 1 to 3%. Delay between admission and randomization was around 1.6 to 1.9 days. Active bleeding was seen in around 80% of the patients. Creatinine clearance was 45 in both the groups. Now, if we look in terms of the transfusions that were given and the hemoglobin levels, at admission, the hemoglobin level was roughly 10 in both the groups. Just prior to randomization, it was around 9. Lowest value during hospital stay was 8.3 in restrictive group, 8.8 in the liberal group. At discharge, it was 9.7 in the restrictive group and 11.1 in the liberal group. Number of transfusions received more than 1 unit was almost 100% in the liberal group and around 35% in the restrictive group. Unit transfused was 342 in restrictive versus 758. So almost double the transfusions were received in the liberal group. Now, the duration of RBC storage was around 20 days. The units of which data were available was around 90 and 300. The other transfusions were roughly similar. FFP 3 versus 7. Platelet was 4 versus 6. Now, if you look at the primary outcome was not much different. It was similar in both the groups, 11% versus 14%, even if we include per protocol or intention to treat analysis. Secondary outcomes were almost similar in both the groups. There were no major differences. If we look in terms of the Kaplan-Meier curves, the risk of major adverse effects were almost similar in both the groups. There was no statistical significance. If we look in terms of the adverse effects, 11% in both the groups. AKI was slightly more in restrictive group. Acute heart failure similar. Allergic reactions 3 in restrictive group. ARDS was more in liberal group and MODS was also more in liberal group. Infection related complications were more in the liberal group. So if we look overall, infections and adverse effects were more in the liberal group. Only AKI was more in the restrictive group. So the author's conclusion was that among patients with AMI and anemia, a restrictive compared to liberal transfusion strategy resulted in a non-inferior rate of major cardiovascular events at day 30. The limitations of this trial. It was a moderate sized trial, thus was not powered to evaluate the superiority of either of these strategies. A non-inferiority margin of 1.25 includes potentially clinically important harm and may be considered too large to rule out that there was no harm of any particular strategy. The observed confidence limits ranged up to 18% increase in cardiac events, which could be clinically meaningful. Since it was a non-blinded study with clinical parameters as outcome, there is an amount of bias because the clinician is aware of the group the patient is in, and then they will make the clinical assessment. Anemia, bleeding, and dilution were included in eligible population. Since hemoglobin was the target based on which transfusion were given, a hemoglobin level could be low because of chronic anemia, also because of ongoing bleeding, and also because of dilution and multiple times the samples that are collected. So it is difficult to eliminate which patient was having which hemoglobin low due to which reason. The follow up was only for 30 days. The 1 year follow up and the cost effectiveness analysis will be a separate paper. So if we consider this paper, it was short follow up period with only 30 days of data being presented. So our take is the use of restrictive strategy appears to have similar outcomes. The study is too limited, and with a non inferiority design, it is difficult to change practice based on the data that has been presented in this study. So, the transfusion should be done taking individual patient information as of now until we get more robust and conclusive and superiority studies showing effectiveness of one strategy over another. So, as of now, this particular study does not change our practice, and we will continue to use hemoglobin as a trigger and a level of around 10 for transfusion in MI patients. Thank you for your patience and check our website for further information.